بس هلا ارجع اعمل شير سكرين. معمول شير سكرين، تفتح بس الباوربوينت.
ايوه لا اي واحده
اللي هي هون ونكبر الشاشه. اتوقع اسالهم اذا الشير مبين عندهم.
شباب الشير مبين عندكم سكرين هلا؟
كل شيء تمام دكتور.
اوكي الله يعطيك العافيه. اوكي تفضلي. تفضل. Today we are going to discuss cancer control and medical screening. We'll focus mainly will be on cancer control and key concepts related to medical screening. يعني. Objective of this meeting is to overview of the preventive medicine and cancer control, cancer incidence in Jordan, and it's very important for you guys at least to know the commonest 5 cancers for the general population and to know for the pediatric age group what are the commonest 3 cancers. So for males and females, for the whole population, for males, females, we need to know the top 5 cancers, and also for the pediatrics to know the commonest 3 cancers. Definition of prevention is actions aimed to eradicate and eliminate or minimize impact disease or disability. If none of these is feasible, retarding the progress of disease or disability. What do you mean if none of these is not feasible? What do you mean by that? Yes, example for موبايل ممنوع بالقاعة. سؤال بالأخير. مثال type 2 diabetes for example. Okay, we can't cure it. Okay, but we can what? Improve اللي هو disease. We can control diabetes. We can prevent complications. تمام, and we can improve the quality of life. تمام. So it's not only just to cure the disease. Our main target actually to control disease and the risk factors level. If we can't, if the disease already is there, we need to cure the disease. If we can't cure the disease, we need to prevent complications, recurrence, etc. Okay. This is the levels of prevention. At the primary health care, we need to look at the risk factors. We look for vaccination. These are things like prevention of risk factor, like control of smoking, physical activity, vaccines. That are primary prevention. This has not started yet. Once these start at the asymptomatic stage, we have the secondary prevention. Secondary prevention aims to do 2 things. First one is to take disease as early as possible and to try to change the natural history and also to cure the disease. What we can do at the asymptomatic stage. For example, we know about the breast cancer screening, for example. Okay, the idea is to pick the cancer before it's palpable, before the patient feel that. هلا في عنا another big issue في الأردن في الريجن كمان هي pre-diabetes for example. Okay, هلا most of the case type 2 diabetes here incidentally a patient start to have symptoms and then we pick them and diagnose diabetes. Hello, we know there is a stage we call it pre-diabetes. The patient will have impaired fasting glucose or impaired the postprandial glycemia, or they عندهم HbA1c from 6.5 5.6 or 6.5. هلا unfortunately in most of the countries in the region إنه بنحكي للpatient just to improve their lifestyles and regular follow-up. هلا we can at least يعني delay the onset of type 2 diabetes by 10 years or prevent it completely through combination of lifestyle plus metformin extended release. We start at dose 75 then we adjust the dose accordingly. تمام. هلا في أدوية ثانية زي بايجلوتيزون. الهدف منها إنه في عنا يعني big issue actually. مثلا هلا عنا البريست كانسر unfortunately الكيسز بيجوا عنا بأدفانس ستيج. هلا عنا type 2 diabetes نفس الشيء. هلا الهايبرتنشن احنا بالكلينيكال بريفنتيف ميديسن مثلا كنا نحكي زمان إنه 140 to 160, this is initial hypertension, we should treat for it, even if we give half dose to the patient. كان الكارديولوجي لا يستنوا على 160. هلا كل الإيفيدنس في العالم صار نبلش تريتمنت على الهايبرتنشن على 140. ليش؟ لأنه في عندنا reversible arterial changes. لو استنينا أكثر بصير عندنا irreversible changes. هاي على long term complication هي بنبلش نعالج early. هاي هي تخصص الجديد هو الكلينيكال بريفنتيف ميديسن. يعني بنعالج حتى بالفاميليال كانسر بنحكي لكم عنها كمان شوي. بنعالج البيشنت قبل ما يصير عندهم كانسر من الايرلي ستيج، من عمر 25 بلش مع الفيميلز نعمل فولاب. وفي شغلات حتى للميلز. هلا نيجي نحكي على البري دايابيتس، ما بصير حدا في عندكم حدا بالعيله عندكم فاميلي هيستوري او اي حدا فحص كان عنده التراكمي 5.6 ل 6.5 ما بصير يتركوا بدون علاج. اوكي للاسف كثير مره بلشنا عياده باربد عمال كنا نحكي للبيشنتس انه بدنا تعال اعمل هالفحص مثلا، خاصه كان مش موجود بيعمل برا، بيحكوا له المختبر او الزملاء الثانيين بيحكوا له تعال بعد سنه او سنتين، بتحول من بري دايابيتس لتايب 2 دايابيتس. تمام. هلا ليش كمان شوي بنحكي عن بريست كانسر؟ صبايا the only way to reduce يعني شباب the only way to reduce اللي هو المورتاليتي of breast cancer is mammography screening. اوكي عن طريق الاسيمتوماتيك ستيج. مجرد ما الكانسر بالبابل you will not change the overall mortality. فthis is يعني كل اللي بنشوف يعني unfortunately يعني when I was based in the UK we have never seen any مثلا breast self examination ولا doctor examination. لا it's too late. We should focus على preclinical stage اللي هي asymptomatic stage. This is where you can do. Unfortunately يعني في الدول العربية كلياتنا الابتيك ريت للماموجراف سكرينينج ما بوصل 5%، 3% من التارجت بوبيليشن. عندنا بالاردن 20,000 من 1,100,000 تقريبا. تمام. فهاي يعني بس اتليست كل فيميلز عمر 40 ل 70 they should have ماموجراف سكرينينج بالاردن. اي حدا عندنا والدنا والدتنا اخوالنا اعمامنا جدودنا كلياتهم لازم نعمل لهم سكرينينج للتايب 2 دايابيتس. تمام بعد العمر 40 في بلادنا خاصه عنده فاميلي هيستوري. بأكد لكم you can prevent many cases of type 2 diabetes. The same for the hypertension. Okay. هلا the second goal of اللي هو second prevention اللي هو cure to cure the disease. We have this is why we need to have clinical guidelines to يعني to cure the disease based on the latest evidence. هلا إذا ما كان في عنا cure للديزيز، عنا type 2 diabetes، عنا terminal cancer, we cannot cure. We need to improve their quality of life through tertiary prevention. tertiary prevention will improve the quality of life, psychology, reduce disabilities, كمان to prevent recurrence of the disease. Okay. Complications, yes. هلا في عنا شيء اسمه quaternary prevention. quaternary prevention هي بسموها حاليا evidence based medicine. Quaternary prevention is to manage the patient in the right way, to have clear case definition, to avoid over testing. هلا عندنا في البلد للاسف لو شفنا في have around more than 700 يعني private healthcare centers. Once we prescribe just at each center, if we have just on daily basis 10 unnecessary tests for patients, if you multiply this by 300 working days by 700 centers, you see the huge loss of resources. فبالتالي when we write a test for the patient, we need to be sure that we are writing this test for a purpose. Okay. When we treat the patient, we need to treat based on the clinical evidence. ها هي نسميها evidence based medicine. Previously we were calling that as quaternary prevention. Okay. الهون بس يعني المورتاليتي بالسيرفايكال كانسر. You know why this يعني cancer dropped over time in these countries, cervical cancer in Western countries, simply because of the HPV virus vaccine. Okay. And cervical cancer screening. Okay. طبعا cervical cancer screening بالأردن is not within the communist 10 or even 20 cancer. It's not a priority for our country. We have other priorities, but in Western countries it's a priority. تمام. Because they have different sexual and يعني life styles. That's why عندهم incidence عالي كثير، خصوصا مع presence of high prevalence of HPV virus, human papillomavirus positivity. السكوب preventive medicine. في عندنا ايش بنسميه high risk versus low risk، في عندنا high risk versus average risk. اوكي. هلا each intervention has its advantages and disadvantages يعني. اوكي. هلا لو جينا نطلع مثلا على الكنترول اوف ischemic heart disease. اوكي. لو جينا على الهاي ريسك جروبس، الناس اللي they have strong family history عندهم residence different risk factors. تمام. هلا لو حكينا على and this will work، بس لو جينا على country في عندنا زي الأردن 35% of mortality due to ischemic heart disease. فالريسك فاكتورز are very common. السموكين uptake more than 70% في الميلز، عندنا السولت intake high، عندنا الفيزيكال activity. فبالتالي هون we work at community level rather than working at high risk groups. اوكي. فبالتالي we need to try to shift مثلا السولت intake لكل الكوميونتي، الفيزيكال اكتيفيتي لكل الكوميونتي، السموكين ريت لكل الكوميونتي. تمام. بينما جينا على شيء ثاني، مثلا كان في عندنا يعني مثلا في عندنا هاي ريسك جروبز، مثلا نحكي مثلا على على مثلا فاميليال كانسر، الناس اللي عندهم سترونج جينيتيك ميوتيشن مثلا للكانسر سواء بريست او اوفرين كانسر مثلا. هون بالتالي انا بدي اشتغل على الناس اللي عندهم هاي ريسك rather than the whole population. ما نقدرش نعمل جينيتيك تيستينج لكل الناس. اوكي، ففي عندنا بالانس بين هاي ريسك فيرسس الافريج ريسك. شو اكثر عوامل تحدد لي من اهم عاملين كانوا بحددوا لنا انه to work through the high risk or versus average risk اللي هو كمان النون ريسك فاكتورز. هذا كثير بعض الدول النامية they're trying to يعني developing country trying to look for breast cancer control through الكنترول of risk factors. تمام، بحاول يعمل سكرينينج مثلا في ميز عن risk factors معينة. Why we in medical screening or preventive medicine we are not in favor of this approach. ليش؟ لأنه لو عملنا سكرينينج لكل الفيميلز عندهم كل النون ريسك فاكتورز we are going to pick only 30% of the cases. Now there are many other environmental, other genetics related factors unknown. From this case, if you have a great national program for breast cancer prevention based on the risk factors, فبالتالي you will not pick these cases. You are going to pick only 30%. تمام؟ لو اشتغلنا على family cancer هون بيشتغل على risk factors لأنه خلص اللي عندهم very strong family history most likely to be positive على genetic mutation بيشتغل عليهم as familial cancer. تمام؟ لو جينا على lung cancer لكن نحكي احنا بالبريست كانسر انه the best way to يعني to reduce mortality morbidity breast cancer is to screen asymptomatic cases through mammography screening. تمام؟ From the age of 40 اللي عندهم familial cancer we start with them at the age 25 we at least we do BRCA and BRCA2 mutation if they have a family member positive for the BRCA mutation. باللنج كانسر شو المين كنترول في lung cancer؟ Yes, thank you very much. The key thing to reduce lung cancer incidence اللي هو smoking cessation. تمام؟ هلا فيها different approaches نعمل screening at least اللي heavy smokers كذا بس the right approach to control اللي هو mainly على risk factors مثل يعني في عندنا some occupational lung cancer في كمان mainly هو smoking cessation. لو جينا على colorectal cancer في عندنا combination screening وفي عندنا كمان control of risk factors. ف it's disease by disease. تمام؟ حكينا ischemic heart disease mainly to work at risk factors for the whole community rather than working at the high risk groups. But هلا because we don't have that successful community programs we do some opportunistic control through يعني primary health care centers. اجانا واحد عنده risk family history strong في عنده certain risk factors we start to control at the individual level rather than the community level. But the most successful approach is for the ischemic heart disease the community control of risk factors. هلا الهاي ريسك ابروتش مثل ما حكينا زي الفاميليا كانسر الناس اللي عندهم strong family history يعني we did a study in Jordan on females who have a strong family history of breast ovarian cancer according to NICE guidelines. مش اي حد عنده family history بس عنده very strong family history. Out of 200 females we screened them we had يعني 50 patients were positive for BRCA and BRCA2 mutations. هذول 50 طلعنا حتى ضمنهم يعني 2 novel mutations are reported كمان. هذول للاسف هذول 50 females هذول autosomal dominant gene half of the family members will carry the gene. فإذا عندها if she has for example 3 sisters 3 مثلا 2 brothers 3 auntie half of the family will be positive for these mutations. فلو كان عندها 10 first degree relatives 5 of them will carry the mutation. Those who carry the mutation 70 to 90% of them will develop breast cancer or ovarian cancer and some of them will develop pancreatic cancer. Well, male members will be at risk also for prostate cancer. And these cancers are resistant to standard treatment. So you can see why it's very important to work at different levels of preventive medicine. This is the high risk strategies زي ما حكينا. For example, it's different from one disease to another and also from one intervention to another. يعني حكينا familial cancer we work at high risk strategy. General screening we don't work at the high risk approach. We are going to pick only 30% of the cases. Okay. هاي الماس strategy اللي هو high risk approach اللي هو to work at the whole population. طبعا هون في عندنا age risk. From when we are going to screen from the age 40 to 69 we are talking about the age risk. Okay. A reduction of salt intake. شباب, something that we are missing in our countries اللي هو التيست باد عندنا they are used to high salt intake. If we cut salt immediately, people will not like the taste of food. So the right way to reduce salt intake اللي هو gradual reduction of salt intake. Try it at yourself at home. You'll see that it will help actually. بس احنا مش يعني unfortunately the salt يعني taste it's dominant in our food in our region يعني. But the only way to improve that and even to feel the taste of food in a much better way is to reduce salt gradually and see the impact. If you are going to reduce salt intake over 6 months time, you're going to reduce the blood pressure for any person by 10 to 20 millimeter mercury. It can reduce the actual blood pressure dramatically. If we are talking about individuals, about the community, but we need to do it gradually rather than suddenly. These are the top 10 cancers for Jordanians. As we expect, breast cancer is the leading one, followed by colorectal cancer, followed by lymphoma. For example, some of these cancers we don't know the actual numbers. We don't do postpartum. For example, a female died at the age of 18. No one will do postpartum to see if she has, for example, especially those with this breast and those who cannot feel the lump by themselves. They might have cancer without knowing. Okay, so, but at least for the recorded cases, we have 1,302. And this is a very high number for a population like Jordan, but still the incidence in Jordan is lower than the international incidence. Do you know why? Incidence in our region, our country of breast cancer is much lower than reported in Western countries. Someone said we don't have screening. Yes, it will affect the incidence, especially in the first rounds of screening. And because the population in Jordan, if we look at the incidence for the age above 18, because of the young population is more than the elderly. But if you look at the age standardized incidence, still you see it will be higher. So if you look at the incidence of breast cancer above the age 50, and no, you see it's maybe close to the international standards. But if you look at the age there are other factors like such as breastfeeding, use of contraceptive. There are many other factors that affect the incidence of breast cancer. But until date, the incidence in our region is smaller than Western countries. Okay, for different socioeconomic factors and also for the age distribution. The main worries for us actually, that's why we are trying to have regular mass screening for breast cancer. The population pyramid is changing in our region, and the number of people above the age 50 is increasing, and this will increase the incidence of cancer and other chronic illnesses. فلعنا breast, colorectal cancer, lymphoma, lung, thyroid. This is for both males and females. Okay. If we look at males, colorectal cancer followed by lung, prostate, and they are close actually. Lung and colorectal, prostate, bladder, non-Hodgkin lymphoma, leukemia, stomach. Colorectal cancer, it's mainly can be controlled by different socioeconomic factors. Okay. Lung, smoking. Okay. Bladder, smoking. Bladder, you will not see this bladder cancer in Western countries at all within the top 10 cancers. In our region, simply because smoking, there are some industrial risk factors كمان للبladder cancer, but mainly it's bladder smoking in our region. Okay. Heavy smokers at high risk of lung cancer plus the bladder cancer. Okay. Lymphoma is both cancer, smoking, and other factors. The thing that's also worrying me actually to see stomach cancer in Jordan within the communist 10 cancers. It's 7 in males and 10 in female. It's highly dangerous. It could be to Helicobacter pylori incidence is high in our region, but I'm worried also hearing from some colleagues شاب تشوفوا للاسف سيل الزرق عندنا بالاردن كثير ناس للاسف people are using vegetables from that area. Okay, and this mainly the كلها industrial waste, and unfortunately there is much control should be done there, because anyone who is using consuming these fruits and vegetables regularly, they are at high risk of stomach cancer with time. Okay. For whether it's Helicobacter pylori or industrial pollution, we don't know yet, but it's highly alarming to see stomach cancer and in males and females within the top 10. It's high in countries like Oman, in countries like مثلا شوي in Egypt, شوي بالجلف ريجن بشكل عام عمان قطر الكويت because they use high salt intake بالخاصة salted fish. اوكي بس in our region our diet is different. بتشوف هاي المادة على المخلل البيض اللي فوق هاي نايتريت هاي stomach cancer على السريع. الفيميل في عندنا مشكلة الثايرويد. in addition to the هل هي لو بدنا نحكي نتيجة مثلا اليوز اوف كف سيرب should be males and females صح؟ بس mainly females. هل هي due to يعني there are different colleagues هلا working شوي بالسعودية على موضوع الثايرويد كانسر. thyroid cancer there are different hypotheses إلها. ممكن females that are staying at home more especially يعني non-working females. طبيعة صناعة البيوت عندنا في بلادنا اسمنت وغيرها بيكون فيها يمكن some يعني ionizing radiation أو some sort of radiation that's leading to increased thyroid cancer في بلادنا. فهلا there is much work is done but until now we don't know يعني whether it's something related to pregnancy, some medication that they use. بس بشكل عام it's thyroid cancer is very common in females بالأردن والسعودية. I personally think it might be related ل indoor radons أو indoor other يعني things related to the يعني industry housing industry في بلادنا يعني. للأسف lung cancer is increasing بالفيميلز نتيجة الأرجيل اللي صارت محللة على الفيميلز بينما التدخين ممنوع يعني بس الأرجيل مسموحة يعني. كم حدا فيكم أرجل؟ إن شاء الله واحد. طبعا ovarian cancer we have these cases most likely to be familial so they can be prevented. Okay. هلا in pediatric age group the commonest is as expected leukemia, brain CNS lymphoma, okay, bone and soft tissues. To go through the screening we have screening شباب the key thing that you as medical graduates need to know screening is regular systematic application. What do you mean by regular? If you screen a female for breast cancer, we need to do it, repeat that after 2 years or 3 years, according to the screening table that we decide on, okay? If we screen someone for pre-diabetes or diabetes, we need to repeat that on a regular basis, okay? Not just one time screening. I've seen many studies coming from the region looking for breast cancer screening. They ask question, have you ever had mammograph screening? One time will not be that helpful, okay? What's the main systematic? The key issue for all screening programs in the Middle East, and except maybe Bahrain because they have small population size, but other countries in the region, we don't apply systematic screening. We have what we call scattered campaigns. What do you mean by systematic application of screening? If حكينا عن الكرك governor بدنا نعمل screening للفيميلز في الكرك يقول as systematic application of يعني الماموجرام. We have 300 working days. تمام إذا كان الانترفال تبعتنا نحكي every 2 years time for example تعمل round screening ففي عنا 600 working days. تمام نجي we divide الكرك into different areas and we get the recording من ال civil registry those age 40 to 69 and we have like a map of including them over time. مش بدنا we cannot for example if we have 10,000 eligible females بالكرك for mammograph screening if we cannot ask for all of them to come in this month. And this is the difference between systematic screening and scattered campaigns. Scattered campaigns نعمل big media هون وهون بدنا encourage females to go for screening وعن خلال this أكتوبر مثلا بأكتوبر إنه to increase the uptake نوصل 500,000 female بمحافظة الكرك. And this is not the right way. And next year we'll have the same approach and maybe the same female who will come this year, she will come next year. Okay. The right way is to have records. We divide the Karak government into areas. بيجينا على مؤتة for example, those in مؤتة will have a map to invite them over 2 years time, and the number will be very small. By the end, you will end by inviting 5-10 females every day. Okay, so you can easily achieve more than 70% uptake rate. But يعني هلا if we see a lecture for example outside. يعني when you are entering the university, if you see there's a lecture for medical students or students about their career, You might attend or you might not attend, okay? Maybe if they do more promotion, maybe you have a chance to attend every 10 few guys, maybe 5 or 3 or 4 will attend this lecture. To receive a lecture, a phone call by someone and letter directed to your name saying that you, for example, Ahmed, Muhammad, etc. This lecture is important to you because 1, 2, 3, 4, and someone follow that by phone call to you. Your chance to attend is much higher than to see general advertisement, okay? This is the same approach for breast cancer screening that's applied in the US, in Sweden, in the UK. This is the main difference. Females are divided into according to their location, over 300 or 330 working days, and they're invited on a regular basis, and they attend the screening because someone is doing the follow-up personally with them. They receive a letter directed to their name and import why it's important for you to attend breast cancer screening or cervical cancer screening, okay? And this is followed also by reminders. So you know this is very important to you personally, okay? Not just for everyone. Well, there are different aims of medical screening, like we need to improve, like the key thing to improve prognosis, reduce mortality, okay? And we do screening sometimes for certain infections similar to what happened with COVID-19 to prevent the public from communicable diseases, to allocate resources, okay? And also to do research to understand the natural history of disease when you do screening and we pick the disease early. You can see in 1989, when the UK introduced the breast cancer screening, you can see the mortality of breast cancer started to reduce gradually, okay? Opportunistic early detection, you are working at a country where there is no regular screening similar to Jordan. There is not much you can do. At least you advise patients coming to your clinic to do 1, 2, 3, 4, okay? To do, for example, a female, her age is 50, you advise her to do mammograph screening, to do, for example, to check her blood pressure, to check her glucose profile, okay? And lipid profile. Screening versus diagnosis. There's a big difference between screening and diagnosis. What's the key difference? Screening, for example, breast cancer screening, there's disease already started. Screening, you go for the patient who is asymptomatic. They don't know that they have the disease. Early diagnosis, patient will come to you and you need to suspect that they have cancer. Unfortunately, in our region, it's not just we don't have screening, and we have major issue of delay in diagnosis. A delay in presentation, patient will have the symptom signs, but unfortunately they miss it. Or they are worried that I might be diagnosed with cancer, I don't want to see medical advice, okay? Diagnosis, unfortunately, they are seen by different GPs, by different specialties, and they suspect something else, and they keep delaying them from diagnosis. Okay, so this is the key delays for the diagnosis. So we have an issue of patient delay, we have diagnosis delay, but because of political pressure in our country, when someone is diagnosed with cancer, they need treatment immediately. You don't have the treatment delay, but we have presentation delay and we have diagnosis delay. And what we can work at the community level for the patient delay, but also much work should be done for primary healthcare physicians and other specialties for diagnosis delay. Disastrous result I have seen in the paper that we did the study on breast cancer and colorectal cancer. Colorectal cancer, unfortunately, there are tens or hundreds of patients annually. They are coming to clinical presentation with complete intestinal obstruction because they have been taking laxative for 3-4 years. Okay, they go to the GP, they prescribe laxative without referring them. You study at medicine that, you know, if someone has chronic constipation, you need to refer them for colonoscope. Okay, unfortunately, these patients are taken from the pharmacy, they take laxatives, they take it from GPs, etc., without being diagnosed for the cause. Okay, and this is a major issue in the country here. So I'm not going to go through the criteria screening, just to go through them quickly. We need to have a well-defined disorder. For example, if I want to screen for pre-diabetes, I need to have a clear definition for it. For stage 0 cancer, the same. We need to understand the epidemiology to know it's a major health problem, to understand the natural history. What's the value of screening, for example, for pre-diabetes, if I don't know that the intervention will have an impact, okay? For example, prostate cancer screening, we don't encourage it at all. Do you know why? Because if we pick the prostate cancer now, or if we wait until it presents clinically, it will not affect the survival or quality of life or morbidity. Okay, so we need to understand the natural history. Unlike prostate cancer is the colorectal cancer or breast cancer. If we detect the disease now, we are going to reduce the mortality and morbidity. Okay, and the prevalence of undiagnosed cases. And if we are going to screen, for example, for leukemia, leukemia will present immediately. Patient will present abruptly with pancytopenia, and they will have clinical features. So you're going to take the cases. So if you screen for them, you'll not pick cases with undiagnosed leukemia. Okay. While if you look at breast cancer, you are going to take most cases in stage 0. They will be on stage 1, some of them with undiagnosed cases. Okay. The best to control risk factor, not screen for risk factor. Unfortunately, the common practice previously in the West and now in our region, we screen for hyperlipidemia. We should control the risk factor at the community level rather than screening for the risk factor. And then we screen for the disease rather than the risk factor. Our screening program should affect either mortality or morbidity or the quality of life and psychology. For example, we did a clinical trial on the value of screening for adult hypothyroidism. The main outcome was quality of life. If you detect the patient early, you are going to improve their overall quality of life. Screening tests should be safe, inexpensive, acceptable, reliable, and valid. And we'll discuss this in another lecture. But at least you need to know that the test is not expensive, so it's affordable for the community level and acceptable, and it should be a good test for screening. What do you mean by screening test validity? If we screen, for example, group from the community, if we have patient with disease, your screening test is sensitive or detection rate is high if it's going to pick the number of cases with positive disease. Okay. If we label someone who's healthy as healthy, this is specificity. Okay. Sensitivity or detection rate is you are going to find the disease when it's present. Okay. Specificity is the ability to screen tool to label someone as healthy when they don't have the disease. For screening programs, the key two tests are sensitivity or detection rate and the false positive rate. Why is false positive rate? When you do, for example, breast cancer screening, if the false positive rate is high, you are going to expose the females for further tests, fine needle aspiration, histopathology, and this will have financial burden on the test. It will have more cost for the screening, and also it will have psychological impact and distress for the patients. Okay. If we do, for example, like the fecal immunochemical test for the colorectal cancer, the false positive rate, like the hemoccult blood test, the false positive rate is high. This leads to high number of people are having the colonoscope without a need for it. Okay. And this is the detection rate and specificity. So we have disease, sensitivity is A over C. The ability to find the disease when it's present, A over A plus C. In the ideal situation, this will be 100%, this is 0. Okay. When disease is absent, that is B over, and you label the patient as healthy. This is B over D is the, D is true negative. So the specificity will be D over D plus B. Okay. The ability to label someone as healthy, true negative, from those who are labeled as healthy. Okay. This group B are false positive. You label someone who's healthy as they have the disease. Okay. So specificity will be A, D, those who are healthy, and you label them as healthy, over D plus B. B, this is someone who's healthy, but you label them as disease 1. And this is what increases the false positive rate. Okay. Not going to go through this, test how to calculate this one and this one, but just show you examples. For example, unfortunately, until date in Jordan, the screening test for colorectal cancer male is hemoccult blood. It's affected by dietary factors, by many other factors. We should stop using the hemoccult blood in Jordan and use the fecal immunochemical test. Okay, it works on the globin, not just the heme. Okay. So it can detect upper lower GI bleeding as well. The key thing, if you want to do screening in any country for any disease, there's a agreed plan for the further investigations, diagnosis, and treatment. The human right, the community right, if you pick anyone with any disease, is to provide treatment for them. Okay? So we don't do screening without intervention. We did study one, for example, a few years ago on the national hypothyroidism. فكان في عندنا كونسيرن من بعض الزملاء انه انه those who don't have medical insurance, okay, they are not covered by MOH or RMS or private sector. We did necessary steps to have coverage for those who are screened and they become positive for hypothyroidism to be insured if they are positive. And this is why we need to ensure that, for example, you are doing screening for pre-diabetes. What's your next test? To do GTT, okay? If you're going to screen for breast cancer, if it's positive, are going to have fine needle aspiration? Who's going to do it? Who's covering the cost for that test? And do you have enough treatment, available treatment for managing these patients or not? Okay. And systematic application is the key thing. Guys, the key thing is the pilot study. For me, the ideal situation, I want to do screening in Jordan for breast cancer, colorectal cancer, for hypothyroidism, for diabetes, for hypertension, for hyperlipidemia. I will not encourage for it because it's risk factor. But for many diseases, we can do screening. Okay. So to know the screening test should be cost effective. What do you mean by cost effective? That. عفوا انت حكيتوا لي على الثنتين. خلص اوكي ان شاء الله. اوكي هلا we'll finish in 10 minutes. The pilot test is, it has different objectives. The pilot test, if I want to do, for example, the rigorous screening for breast cancer in Jordan, I need to do it in one area that present Jordan to see what is the acceptability, feasibility. Can I try to screen 30,000 females بالكارك كل response rate يطلع عندي 5% أو 10% أو 20%. فبالتالي I find it's not feasible to do it. Okay? Or I'll learn how to do the right way to invite women في الأردن. It's a learning experience for me, the pilot screening. Okay? I need to check whether my radiologists are working well. كيف technicians at the centers, are they having proper film ولا لا؟ radiologists اللي معانا should be double reader. Are they always aligned في البوزيتيفيتي ريت تبعتهم؟ اوكي. شو الكوست تبع التست؟ اذا بدي اطبق انا هون بحكي عن 20,000 females او 30,000 females مثلا بالجنوب. فام talking about, if we are talking about 1 million and 100,000 women across Jordan, what is the cost for the whole program? I cannot calculate the cost unless I do a pilot test in one area. Okay. So what are the barriers for screening? What are the best way to invite women? What is the right approach for the techniques بيستخدموها التكنيشنز اللي عندنا؟ هل do you have enough radiologists in place for the whole country ولا لا؟ اوكي؟ كل هاي الامور لازم تكون عارفينها. مين بده يعمل fine needle aspiration؟ هل في عندنا system for management and where should be managed, they should be managed. هاي كل الامور should be studied بالبايلوت فيز. هلا بالاخير يمكن يطلع عنا البرنامج cost effective او مش cost effective, feasible مش feasible، نعرف كل الامور هاي عن طريق البايلوت فيز. صوت ورا. هلا if you are going to do for example screening for 10,000 females بالكرك بمحافظة الكرك مثلا. اوكي. I need to look at the how to pick women there. يجينا والله في عندنا هون مركز صحي X ومركز صحي 3 كذا. we have different areas, we have different healthcare centers. هون في عندي records للفيميلز اللي ساكنين بالمنطقة عن طريق الأحوال المدنية. I invite them through this one and arrange through central system to give them an appointment. هلا if you have 10,000 females, I'm not going to invite them over 1 month time. I know that I have 300 working days. I know that if I'm going to screen them over 2 years time, I have 600 working days. So I distribute my target population over يعني اللي هو over 2 years. هلا I gave this example, I think, in different countries in the region. That is this one. In Algeria, this example I think from Algeria. In Algeria, they have 4 million women aged 40 to 70. Okay. And if I'm going to screen them over 2 years' time, so I need in 1 year to screen 2 million females. Yes. My target program is to have 75 response rate. In 1 year, I have 1.5 million females to be screened. Okay. If I have 300 working days and you have 6 days work, and for example, assume that there are 8 main districts, بيطلع لنا around 600 to 225 to be screened on daily basis. Okay. If we have in Algeria, they have around 50 يعني ولايات بسموهم 625 over 441 centers. شو بيطلع لنا العدد؟ We have 15 females to be seen at each center. Okay. If each center has 2 mammograms, you can see from 9 to 5, 1 mammogram is enough for them. One of the issues I think in Jordan for the mammograph screening, that the technician is the one who complete the form. In the UK, there would be a receptionist, medical secretary, it's called, and she complete the information from the patient, and the radiographer to have 6 to 8 films per hour. This is the standard. So these 15 can be seen over 2 hours. Let us say for 1 day. We started by 4 million females, which is a big number. If you tell any decision maker that, you tell you it's impossible to screen 4 million females in Algeria, or 75% of 3 million, for example. But if you split the number, they have around 50 governors in Algeria. If you assume the number of centers there, the proper centers, around 41 they reported to me, they have 41 centers in Algeria. So we ended by only 15 women per day. And if you go to any health care center بالأردن هون بتشوفوا بيجي على المركز الصحي فوق ال 40 50 واحد باليوم صح؟ فإتس simple, but you need to make it simplify your program. This is the key thing from the previous slide. Okay. هلا posters, leaflet, media, they are good that people know that there is a disease called breast cancer, but they're not screening approach. Okay. Every eligible person for the screening should receive a personal invitation to take part in the program. And they should have equal opportunity to be screened. Okay. And there should be a reminder. And a system in the UK, for example, we send a letter, followed by a reminder letter, followed by a phone call by the practice nurse. If they don't respond, then the physician will talk to them. And I can reassure you that the uptake rate is above 70%. But if we keep it for the general advertisement, leaflet, media, will have the situation that's currently in Jordan, that we have less than 5% of the women are, they attend the screen. Okay. And we don't know that next year will be the same females or from another, or not. We don't know that because we don't have regular records for the screening. The pilot project, we discussed this previously. No, it will look at the health economics. You need to understand the program, the waiting time, the film quality. Suppose والله هون عندنا في مؤتة في عندنا مركز breast cancer screening or type 2 diabetes screening. So we have around 5-10 people coming for type 2 diabetes screening. They were waiting for more than 1 hour, and the approach for the receptionist or technician, they were not good. The one who's taking blood sample, he was not really well trained phlebotomist. This will affect the uptake in the whole area. Yes. But this is why it's important to do the pilot and to do, once the program is in place, to do the quality, to complete the follow-up. To know why you have the response rate is high there and the response rate is low at another place. Okay. And I feel really sorry about the many countries in the region, including Jordan, and other countries the same. They bought mobile mammograms. They are very expensive techniques, and they spread it between, they move from one place to another. In the UK, they bought the mobile mammograms, I think in 2008 or 10. This is around 21 after they had the complete program. They look at the uptake rate in different places. They did studies to improve the uptake rate. Until they reach a conclusion that there are specific areas for some ethnic minorities, they are rejecting taking the breast cancer screening and they are resisting the screening. And then they started to work on mobile mammograms to increase the uptake in these areas. But in a country where there is no regular systematic screening for breast cancer, to start with very expensive mobile units, it's not really the right approach. The cost for a single mobile unit, you can have, they have, I think, 1 or 2 mobile units in Jordan. Their cost may be enough for the all needed mammograms for the whole country for regular screening. Okay, so this is unfortunately, when the people who are not really expert in medical screening in charge of such program, and this is the impact of having very low uptake of breast cancer screening in the country. And volunteer bias, when you don't have regular systematic screening, those who are healthy will try to go for the screening for diabetes, for hypothyroidism, for breast cancer, colorectal cancer. And this is what we call volunteer bias. Okay. Challenges, validative screening test, for example, screening for colorectal cancer, hemoculture blood, it's available until date. Unfortunately, in most centers in Jordan, it should be stopped, for example. It's not valid for screening for colorectal cancer. You need to have a proper mammogram like the digital one. You need to have a plan to reduce the false positive rate. For example, where I was based in the UK, there should be a double reader policy. In countries like Jordan, we have single reader policy. They did a study on around 20 or 25,000 women. They had single reader, and the second group as clinical trial, there were 2 double readers for the mammogram, independent readers for another 25,000 females. They found it's more cost effective to have double reader because you are going to reduce the false positive rate and false negative rate. When you have double reader, this doesn't mean that your radiologist is not working well, but this will improve the uptake, and this based on evidence. This is why countries like the UK, where they have regular screening, they have double reader rather than single reader. Unfortunately, here in the country, we have big resistance for a double reader. Although everyone should unite for this point based on evidence. Anxiety cause when you label someone as false positive, you'll have a huge anxiety. They might change decisions in their life. They might give, many things will affect, can be affected by labeling someone falsely as cancer patient. And we should have also, as we said, the clear case for the healthcare, how to utilize resources for the positive cases. Quality assurance, once your program is in place, you need to have regular follow-up and to improve your screen program. Just 2 minutes on the cancer control program. You need to have your cancer control program mainly focus on reducing cancer incidence. And once you have certain cancer, to reduce the morbidity and mortality and to prevent cancer recurrence and complication. This can be done by proper management protocol and to improve quality of life of cancer patients. Smoking actually is the key thing, mainly in countries like Jordan, with smoking rate is very high. Okay. The key factors affect survival, treatment, availability, disease, natural history and definition, and the host, and also the availability of early detection screens. If you look at the whole area in the Eastern Mediterranean region, you see lung, bladder, stomach, mainly lung and bladder, stomach are preventable cancers, and we can control them mainly through these factors. Mainly lung and bladder is mainly smoking in our country. Shall smoking cessation programs. There is a big debate between behavioral or psychologists and between us as physicians. I want to tell you 2 things about smoking cessation. Behavioral intervention without pharmaceutical intervention will not work at high success rate. It might work, but at small degree. Smoking is addiction, so you need to give a replacement, nicotine replacement treatment, or to stop through either to give varenicline through to block the receptors, or to give nicotine patches and gum. One of the major challenges for the smoking cessation in Jordan actually, and in Saudi Arabia the same, the smoker will go to the pharmacy and they don't take the right dose. They go to some clinics and they don't take the right dose. For example, a heavy smoker will smoke, for example, 20 cigarettes per day or more. They should have a combination therapy of patches plus lozenges or gum. Based on evidence, meta-analysis showing that the combination therapy is the best treatment for the controlled smoking. And when you give only patches for a heavy smoker, they will have craving episodes during the first month or first few weeks, and they will smoke. So this is why you need to have a combination therapy. So if you know any smoker now or in the future from your patients, try to have a combination therapy, patch, and you taper the dose, and plus اللي هو gum or lozenges اللي هو drops بأول at least the first month. Monotherapy is effective but not as combination therapy. Okay? And if you give, for example, varenicline, you need to give the right right instruction to the patient. Okay? And your advice to the patient. As much time you give to your patient, as much the response will be. There are many studies show that once you give more time to the patient will listen to you. Patient likes to receive advice from their doctor. So you, as medical students, you can do some work on this area to improve at least those around you, at your family, your father, your brother, your mom, your uncle, your aunt, your cousin, anyone you can work with them on the smoking cessation. By advice and also by giving them the right treatment or intervention for smoking cessation. Well, in some countries, there are incentive system for GPs. If you reduce the uptake rate of smoking at your clinic, you are going to have more salary or incentive in the coming year. And just to remind you, always, if you want to have any program for smoking cessation, risk screening, prevention, try always to do a pilot study and then to generalize for the whole country. Thank you very much. I love you.